Hey everyone, this is the Nips and Sips podcast show featuring me. I'm Dr. Jeremy Boyd and my partner in crime over there, Dr. Brandon Cruz. Today we're going to be talking about whether physical therapy or treatment in physical therapy should be standardized. A lot of physical therapy can vary per clinician or clinic. Should we really hone down and really make it one system for certain conditions? But before I get too much into it, Brandon, how's it going?
Going well, Jer. Yeah, this is a great topic I want to talk about, and I don't know if you and I have the answer, quote unquote answer, right, for everybody. I think this is just to make our audience think more so today.
Yeah.
But we have our course coming up this weekend, so I'll be seeing you in about 24 hours or so. Actually, maybe 36 because you come in the morning.
Yeah.
So we have that coming up. I guess drinks, right? We got our drinks. Yeah. I'm drinking. I forget. I poured it like 20 minutes ago now because we were chatting. I think it was Bacardi, some type of rum. So I've been sipping on that for a little bit. That's what I got today. I was about to drink some beer because I have a ton of it. But I was like, let me save some for you and Kyle this weekend.
Yeah, is Kyle a big beer guy? I think he is.
I think he is. Yeah, he's definitely more than I am.
Yeah. Oh, in a random idea, I did go to some breweries this last weekend. And there's a brewery somewhat between the both of us called Founders. Between you and me, ish. It's closer to my hometown, if you remember where I used to live, like closer to South Brunswick. But it has a brewery, and then I don't know what the name of the distillery, but it's a brewery and distillery on one site. And I was like, oh, 100th episode, we should reach out to them, get it live there. You get drinks delivered from distillery. I'm getting a brewery, and God knows what will happen. But that's it.
I like it. What are we at now? What was it, like 60? Episode 60 or 60? We're in the 60s.
We're in the 70s now.
Oh, in 70s.
Published 70s. This will be. I think we're in the mid to late 70s of things that haven't been out to the world yet.
So we're looking at probably spring, summertime then.
Of two per week. Yeah, potentially. Yeah. So from recording, fall. Publishing will probably.
Yeah. I'm not worried about publishing. Actual shooting. Oh, but you want to do it live, so we're gonna have to. We'll figure it out.
We'll figure it out. Right. But just saying, I saw that, and that's where my mind was going.
I love it.
Make it happen. Multiple hour episode, and first one drops wins in the 100th episode. But
all right, sounds good.
But speaking of drinks, my boy TJ, who I get to see this weekend, my main man from Denver, he gave me this beer. He said I had to have it. It's called Prairie Artisan Ales, Seasick Crocodile, which is a great one. It's a holiday beer, and we're a little past the holidays right now, but he said I had to have it. It's a sour ale with cranberries, ginger, cinnamon, and nutmeg. So this is interesting. From my
everything about that sounds great except the sour part. I can't mess with sour beers, man. Those I'll run right to the bathroom.
Oh man, I think the sour game has definitely evolved in the last couple of years, in my opinion. They're like super, almost too much when I first experienced them. I don't know, 7, 8 years to 9 years ago. But now they're a little bit easier on the palate there and the stomach. But yeah, so we'll see how this one goes. Sounds good. Here we go. Cheers. Oh, it smells nice. Ooh. Heavy on the tang, but you can
right after you say it's evolved on the palate. Yeah.
It's calming down a little bit. It's cool because you can kind of taste like the cranberries and the cinnamon to a degree, which I haven't really had with a sour beer. But I'm going to give it a 7.2. Okay.
All right. Funny, a little story for our audience here. Speaking of sour beers, and Jeremy, you enlightened me on this. So when I was out doing my fellowship in Regis. One of the trips, it was during the summer, I stood out for a week, and one of the things I did was check out all the breweries. Not a beer guy, but when in Rome. Mm-hmm. So I think up on like 20th Street or something like that, 21st, 22nd. There's like this whole row, a whole strip of of breweries. I think there might be one distillery. So I'm having these beers and they're pretty good, but my stomach just starts getting wrecked, like bubbly and gassy. I'm like, what's going on? Like I didn't eat anything, whatever. So I had no idea it was the beers. All right. So then you and I were playing golf in the fall at that tournament we had. I don't know if you remember that, like 3 years ago. And then you whooped out a sour beer. I was like, no, I can't fuck with those. Every time I have one of those, my stomach gets irritated, right? And then you're like, oh, it's because of, I don't know, whatever, the bacteria or whatever the fuck. So I was like, oh, all right, makes sense. He's like, yeah, that's what makes it sour. So that was my evolution to sour beers. Clearly, I know nothing about beer. This was a few years ago as well. But so I don't mess with the sour beers. I see it and I run.
I mean, some of them were really, really good. Now they got these like milkshake style sour beers where it honestly looks like someone blend stuff in a smoothie. So it has no resemblance of beer at this point. Those are becoming or blender beers. Those are becoming much, much more popular. But like your standard sour, which I believe is what I'm having, those can be a little bit. But yeah, I believe we'll have to bring Justin on the show one day, but he's a more beer science connoisseur there. But I think originally how sour beers were created was a batch because it's yeast and stuff like that. And then you have to be very, very careful of how you put everything in. And it's got to be kind of a controlled environment as best as it can. A batch has got infected and then still turned out to be pretty okay. So, and then you get sour beers, but sour beers have to be typically in like bigger breweries and that sort of stuff actually separated from your other type of beers because they can actually infect the other beers, which is kind of interesting.
Look at that. Interesting.
From what I hear.
All right.
But hopefully I don't get any flack from the brewery association of sorts.
But you're gonna start your own one day. I feel it. What do you? You're 34.
Mm-hmm.
Oh,
33.
Hold up. I know that. What?
33 now.
Oh, 33. Shit, way off. I know this episode isn't gonna drop, but Dr. J over here just had his 33rd birthday. I'm trying to expedite your age, get you a little closer to mine. He was saying how old I am. But happy birthday to you, brother. It was February 15th. So guys, DM Jeremy when you hear this. Happy birthday. So happy birthday to you, big dog. Almost forgot that. 33. Okay.
The trifecta of birthdays. Because I'm not gonna make it to 333. So it's as good as it gets.
All right. There you go.
Thank you, sir.
Look at that. That's very fitting. How many years you been in business?
4.
Not 3. If it was 3,
I know.
Three. Fuck, you opened up a year too soon.
I know. Hope maybe you
got
a third office somewhere. I didn't add it all up or that sort of stuff. It is what it is. Wasn't thinking that ahead of things at the point, but here we are now.
If you did, you could have done an office a year and have 3 offices, 3 years, 33rd birthday.
Would have been epic. I fudged up, but so one of my people probably make quadfecta. I'll make sure they line it up that crisply.
All right.
But probably be next door. Probably be Justin. He always makes fun of me. He's just like quadfecta. I'm like, you bitch. Can't use my own symbol against me.
He's making or whatever. So all right.
Let's get to chatting.
All right, so enough ranting here. Audience probably like, all right, shut up, get a show on the road.
Yeah.
Standardizing PT. Let's see. Should this start at the entry level program? Should there be some more unified standardization between program curriculums? Does the problem start there? I don't know. I'm just throwing it out there. There are, I think, about 12-ish different approved PT curriculums within CAPTI, so to speak, from what I remember from some fellowship discussions. I may be misquoting that, but 12 really stands out. Is that where everything starts? Is that where some of the problems in our profession start?
I mean, I think so. I think I always say, trying to layer all the people that we teach now, from student physical therapists to our entry levels that come in our place, to our residents, to our fellows in training. of like how you want to have your mindset. Obviously, when you're not exposed to anything as a student physical therapist, or if you volunteer, yeah, maybe standardizing things and laying a good foundation of what's the available evidence for each particular area, I think is a good idea. With the, I guess, explanation that everybody's a N of one. Things do ebb and flow. Test things out, learn from different people. Um, I think it's a good kind of start, but we also see that as a problem as well. As right out of school, it's like my professor said this is what the evidence says, and I'm stuck in this box, and when shit doesn't go right, I have nowhere to go. So I think I like the idea of like evidence informed practice as kind of our guide with things. But when you have nothing to build off of, having some standardizations from some things to look at from objective to also treatment, I think is a good idea. I think we also like, that's one end of the spectrum, is the students or the DPTs, but really is like, maybe we should start standardizing or almost forcing standardizations of our more senior PTs, especially because they're the ones mentoring CIs, whatever it may be, the younger generations, and we see this kind of vicious cycle. If they're stuck in some things from the 80s or 90s or some whacked out stuff, sorry to say it, but and they're teaching the next person, and then it starts to kind of trickle down. How many generations of PTs are we going to have that are practicing, I would say, just downright wrong in a sense, not empowering the profession, making our outcomes look like crap, decreasing our responsibilities because they're passing it along generation to generation. So I don't know how
Who's
that would be.
typically teaching in schools though?
But
The
then
older therapists that are doing some wonky ass outdated shit, and they justify it by, well, my experience. Like that's like what movie is it? It's a Will Ferrell movie where he's like, with all due respect, and then like insults you. And that, I forget the name of it. And then the guy's like, just because you say with all due respect doesn't mean you get to say whatever you want after it. He's like, no,
yes.
yes,
Oh,
that is what all due respect means, right?
yeah.
So it's like that has become the, like if you have any type of experience behind him, well, in my experience, and then that just glosses over everything, and you're scot-free and you can't be touched because your experience says that, and you totally just wash out and disregard any other aspects of EBP or evidence informed or whatever phrase you want to use. It's gonna bother me. What movie is that?
I feel like I saw it very recently because it's like hitting me in the head. I could always look it up, but
I don't think it was Anchorman. All right. Anyway, we'll come back, maybe just in a different episode. I'm gonna rant here while you maybe look it up.
yeah.
I took a course this weekend on dry needling and talk about what you were saying, like some standards, right? And this is just a conversation that it's going to go in circles, it's going to go in different rabbit holes and bunny trails, right?
Was it
But
Talladega
hopefully
Nights?
what happened?
Was it Talladega Nights?
Yes, I think it was Talladega. He was telling his the CEO guy of Dale Enterprise or
Yeah.
whatever. Yeah, good job, good quote there.
Yeah.
All right, it was
Power pool,
Talladega
baby.
Nights. All right, so back to my thing. I was taking a course. I was taking dry needling course, and I was the experienced dry needle in the group. So we were talking about some stuff, and I said, "Okay, what's your asterisk sign?" And the 3/8 PTs just like deer in headlights. I'm like, asterisk sign, and they're like, "What's that?" I'm like, "Comparable sign." They're like, "No." I'm like, "Okay, what do you call it when you do someone's range of motion, you do a treatment, and then you retest it, right?" And then, they're a little perplexed, but then like, oh, they came up with a name. I can't remember it. That's what it was. Something with a C. I think it was concordient sign. Maybe they used that terminology.
Yeah.
Concordient, right? So even that's not standardized, and something as simple as an asterisk sign, okay, there may be multiple names. Cool. Teach all the different names that there could be, or at least the top main ones. So when you go to have a discussion or teach or try and have a reference point to start from, we can all start at the same point, so to speak. We don't even have that. Do we need it? I don't know. That's on the school level. We're not going to go down that route. That's not changing anytime soon. Does it have to change? Is that the good part? I mean, I love, at least the fellowship I was in, that kind of gives you some free reign, especially when you get to a higher level thinking where you can actually critically think and reason through things. Should you have to be put in a box of standardization, which other fellowships do? I've trained other fellows from different programs, and they are very regimented and linear in their thought process. They have to stay within the color, the lines, right? They have to color within the lines. Or luckily, I feel Regis gives you the ability to move things around, ebb and flow, use interchangeable pieces, which obviously you have to get to that point. But that's the education side.
Yeah.
Let's go to the treatment side, where, and we all talk about, right? You're, and how we market too. Oh, your plan of care is individualized to you. Great. That sounds nice. It really does. It's cute. But is that what we're doing? Should you can individualize somebody's plan of care, but it's the shittiest plan of care ever. Is someone going to get better? Is someone going to get better as fast as they could? Should we be at least creating some minimal checkpoints? Like, hey, you could do whatever you want, but you need to do A, B, and C first. You need to assess X, Y, and Z first. And then from there, you can go do whatever. And I'll give some case examples, but what are your thoughts on that topic?
Yeah, I think it maybe from who knows, maybe an outcome measure wise or outcomes altogether. Like, all right, you should maybe push us for that. Then, like, all right, we're not going to tell you exactly how to get there by the steps. And I have my knocks on like protocols, especially for ACLs and that sort of stuff. They say you got to do this, but they never tell you how. But maybe it's like, all right, well, you got to get 5 degrees range of motion here, or you should see an improvement of whatever you want to use an outcome measure, +6 per week or something like that. And when your crappy plan of care isn't achieving that, then, maybe that's something that needs to be standardized. All right. You haven't earned the right to continue treating this person because you're not making outcomes, or you're not improving the person. And those individuals maybe should be standardized in a sense. I think what you said before about whether, concordant sign or comparable sign or functional asterisk, whatever you want to use, they're all kind of similar in a sense. I mean, that should be the bare minimum of what we teach to students or everyone. Like, if you're not aiming to make a progress and track it within sessions, like, I still think that's part of our profession. Is like, some people, it's like, all right, especially this, scripts, it's like you get them, it's like, all right, well, I have 4 weeks, whatever. Oh yeah, I got to do a reval at 10 sessions. Everything in between I don't really care about. But no, it should be beaten into us. It's like, find out whatever is important to the patient, do something, and you should be making meaningful progress towards it. If your treatment's not, then again, you need to evolve, or maybe it's something that the patient's not appropriate for physical therapy. But how often do we get people that don't make any progress and again end up surgery, failing PT? Oh my God. On a random tangent here, I saw New York Times put up a thing about like certain orthopedic procedures shouldn't have to go for surgeries. You should try other things. And I saw it was hundreds of comments. And I read through the articles, like, yeah, those are all things. I know the research on that. Those are all things that if I see those, I'm like, I can treat that person without the need of surgery.
Yeah.
And comments on this, I was hoping people like, that's awesome, that's great, was horrid. It was like everybody was saying, it's like, this is an insurance play. This is, nobody wants to pay for anything. And I just wanted to like comment on everyone. I'm like, no, physical therapy should be able to treat all these things plus some. And again, I guess if we're as crappy as we are, can we blame these people for not wanting to try it, or they have tried it? Maybe these therapists that have poor outcomes. I mean, I know Medicare try to track outcomes and kind of tie it to reimbursement, and people abuse that in their own way. But I think we need to find a way to standardize, or honestly have cuts to the profession. Like, all right, you unfortunately earn the right to continue to treat, because you're just as good as, not even as good as a trainer in a sense, not to knock on trainers, trainers at least will guide you through your exercise. Some people, it's literally you walk in, you do your exercises, you walk right back out. Someone helps, gets the hot pack from the hydroculator. But those people need to get there. So we have, a system, and, state boards, it's like snitch on a place if you know they're doing some dirty stuff. Well, why aren't we
No one's going
going after clinicians? So that's my rant on that sort of stuff. I think we need to.
No, great points. And why do, some of it, people are saying, it's an insurance play. Maybe they had bad experiences at PT because people are doing shitty stuff, outdated stuff. Maybe insurances should reimburse people who have higher credentials and keep them. It's not the best answer, but there is a big difference between the way a fellow trained person treats and somebody who has their doctorate 1 year out. I know way more than day one, PT that comes out, yet we get reimbursed the same. Is that correct? I don't know. These are all things that are just kind of coming up based off of that article. But people also have the perspective that surgery is a quick fix. The amount of people, and I live 5 miles from New York City, I'm in New Jersey, but 5 miles from there, if that, and the amount of people that think, oh, well, I had surgery, I should be good. Like, they think they're getting a brand new body part. Like, they just have no concept of, you were just cut open. We need to rehab this. It's not going to happen on its own. And part of it's the physician's fault, because a lot of them don't even prep their patients. If they're going to get surgery, they should probably start with PT before surgery, just to get them in the routine of what it's going to be like, and hopefully educate them before they go in, when they have maybe a clearer frame of mind. Because, surgeons tell people when they're just coming out of anesthesia, the person's groggy as hell. I don't know if people have had surgery out there. You don't remember anything. The surgeon speaks a mile a minute and then leaves, and you're like, what? I had no idea what's going on. I had a person 2.5 weeks out come in for ACL, rehab after reconstruction, and she's like, yeah, I didn't know I needed PT. Doctor didn't say anything. And then when she went for her 2-week follow-up, he's like, yeah, you should be in PT. She's like, you never said anything. Like, there are so many different layers to the point you brought up in that article, that obviously people commenting, there's going to be truths to everything. But yeah, there's just so many layers. But if we standardize treatment to some extent, does that take away the variability as much? Our people are at least getting the basics, right? Like, well, obviously we talk about manipulation a lot, like an upslope with thoracic manipulation, and whether it's prone or supine, a lumbopelvic, right? If somebody is coming in with that region, you should probably manipulate them, like, no question asked. Like, it's a safe technique. If they don't have any red flags, there's no reason not to. Josh Cleland, this is from the horse's mouth here. He has over 300 publications. I'm in fellowship program, and he's like, these are leafy green techniques. Leafy greens, we benefit from, vegetables and salads and green things in our life as human beings. That technique is the equivalent. Like, we need to encourage that. Yes, we need exercise. Yes, there needs to be some individuality. You can't just go, manipulate everybody. But for most technique, or for most pathologies, should we start to kind of create protocols for the average PT? So you're at least hitting some markers along the way, versus you're going in there and you're just doing, massage, and, like you said, coming in, doing exercise, heat pack, and leaving. Like, there's no skill in that. Like, part of what we get reimbursed for is for a skilled intervention. There's no skill in passing your person off to a high school student for exercises, doing heat or stem or whatever the fuck, and then having that patient leave. And maybe you do a hamstring stretch to them. There's no, a monkey could do that.
So you can do it with a strap. You don't even need
Literally. So
Well,
and I think we tried to do that as a profession with this clinical prediction rules and clinical practice guidelines, but idiot PTs took that the wrong way too, and they don't like it or don't do it. And now, as we're evolving, okay, Chad Cook has come out, death to CPRs, death to CPGs. Where did we go wrong with this? It is, trying to create a baseline or a standard for people doing an injustice as well.
I think it really needs, I hate to say it, but it almost needs to come down. We're still a very insurance-based profession. Is like the insurance companies should maybe, I think that would be the only way that would change people. You can have the greatest of greats teach you. You can have your professors maybe teach you. We get podcasts out to the masses of millions, like Manips and Sips here. Can teach us and that sort of stuff. But let's face it, a lot of times it's just easier to stick to what you're doing, or it falls on deaf ears. But let's say if insurance companies were actually really critically evaluating notes versus just kind of auto denying or whatever it may be, but like, all right, you put this ICD-10 code, or we read your quick assessment, whatever it may be, we see that you failed to implement XYZ that we see should be a standard of care. Leave it like 50%, maybe standard, and maybe 50% little ebbs and flows if you want to add some performance or some other kind of techniques, or obviously some education, or obviously education should be incorporated with everybody. But it's like, we're not going to reimburse you because you failed to implement the best treatment. Versus, they're still paying for ultrasound. All right, we're going to dock you. We're not going to pay you because you're doing ultrasound, and we don't see any evidence to support that. Or we see that you fail to see if there is a meaningful improvement within session or between session. Those are things, and then maybe that will drive. Unfortunately, that will drive people to do that. The big companies are like, all right, we need to do this. Well, and I can see it. Unfortunately, it's like you just need to document it like that.
And that becomes a problem. Then people. Well, I mean, insurance companies need to not be for profit, or say they're for profit. They need to put a cap on what salaries can be for CEOs, what their bonuses can be. There's no way these CEOs of Cigna and Blue Cross and Aetna can pull in, a $20 billion bonus at the end of the year. Meanwhile, they're denying payment. How about people are paying into this? Let them use it. There's more than enough money in there. But then you have people say, oh, well, cash pay will fix that. No, I used to think that as well, but no, because then you become a service industry. We're not a commodity, right? We're a healthcare professional. Then you get the idiots that are marketing, right? You just need to be good enough. What's good enough? Good enough for one patient may not be good enough for another patient. So what's good enough? Right? And their focus becomes on service and marketing, which, trust me, you need that as well. But that can't come at the sacrifice of being a good clinician. Good enough. What does that mean?
Can never be good enough.
So we're clearly not getting to I think we're making more questions from this, which is perfect. Hopefully everyone listening to this begins to think a little more and reflect more on what it is they're doing, or what mission they want to be a part of. Do you want to go work for the mom or the mill, or do you want to go work for maybe a smaller company that has a better culture? that tries to do things better and focuses on these things, trying to move the profession forward?
Mhm.
Or do you go do your own thing? A lot of different options here.
Mhm.
Um,
I think,
so yeah, I really don't have
I
anything
mean, look
else
at
after
it,
that.
be greedy about it. We constantly bitch about what our salaries are. Well, our salaries aren't going to get any better if we constantly suck at what we do. If we have these people who kind of suck and see people for 40, 50, 60 sessions for something that can be easily treated in just a couple, that's going to devalue things. All right, why should we pay this person X amount for 50, 60, 70, hundreds of sessions? I know a couple practices that see people regularly over the triple digit marker. That devalues us. If we can get standardization of certain things, hey, that may fix or help 60% of the people, 70% of the people that come to PT. And maybe that extra level expertise or that fluidity gets the remaining 20, 30%. Then great. We have benefits of both worlds. And then we can actually be like, wow, maybe they'll start forcing it more. So, all right, yeah, we have direct access. Great, wonderful. But maybe it'll start to become a part of the system versus you have that choice. It's like, no, we need you to go to PT first, and you need to have at least this done, try this out before we do that, versus what's it now? Oh, I hurt my low back. I went to my physician. Oh yeah, go try physical therapy. We'll do the MRI when you come
Or
back
just
in
just
3
wait
weeks.
for 2 weeks, do nothing, just rest.
Mhm. That's not that should be standardized. Do not allow that. All right, we're not going to reimburse you for that physician visit
You did
because they
nothing.
gave a shitty advice and they just extended your length of symptoms.
Yeah.
So certain things probably should be, and
But this is what
unfortunately, it
the
gets to a point where things probably have to be docked or not paid or punished to a degree. Before all the punishments I've ever known have always been more like fraud and billing stuff. Whenever we're going to get maybe some punishments for shitty care, I'm not scared of it. I would fucking love it. Wipe out half the competition in the area. So I think that's what we, unfortunately, instead of just everyone being motivated and let's go ham and become the alphas of the neuromusculoskeletal realm. I think it's unfortunately going to be forced elsewhere.
Yeah.
Unfortunately.
Well, where I was going to say the standard comes on the insurance providers like Cigna or Oxford, fucks. They the standard is, I don't know whose standard this is. They give you 4 visits for ACL reconstruction. The fuck is that? I'm good. I'm not that good. I can't,
Yeah,
speed up
my God.
healing.
Yeah.
My view
And
and
is
then they're like, oh, well, based upon our data, it should only take 4 visits. What data are you freaking pulling?
From a 1980 study, and I've had it where I've gone toe to toe, dropping research between Dr. G of Cigna. I'm not gonna specifically name names, but and they're like, no, that's okay.
Yeah.
All right, great. You're not even up for a true peer-to-peer, but it's like they don't care. It's not their problem if they re-tear, and potentially they may be on someone else's insurance next year, or again, just keep rolling the dice, hoping for the best.
Yeah. I've had that's a good thing, knowing your research. I mean, I've done that with and peer-to-peer. It's not even peer-to-peer because you get some nurse practitioner or something, or some peds doctor has no idea what you're doing.
Mhm.
And they start to try and cite research, and if you know the research and you could, like, I had I was just rattling off everything, research, year, author, stats of it, and then like, all right, clearly know your research. All right,
Mhm.
here, and then and they'll cave in.
Mhm.
um
Love it's an
it's becoming
endurance battle
tougher.
of research. It's an
What
endurance battle of research. It's like
Yeah.
holding them online and presenting it,
Yeah.
advocating your case, like even beyond the research of like, we're
Yeah.
doing this, we're doing that. I'm examining this. They still have these deficits that need rehab. We know if we stop rehab here, the statistics are this from this
Yeah.
research. It's almost an endurance battle.
Yeah.
But
Don't
go
get me
ahead.
wrong, they still say no sometimes,
Okay.
but at least you're able to have that conversation. More often than not, I'm able to get a couple extra more than a couple, but their plan of care extended if I'm dealing with an insurance company. But yeah, I mean, the whole system's broken. We're going beyond the scope of this call now, but
yeah, I think that's good. Any final thoughts there, Brandon, on standardization of PT or anything like that?
I'll say this. I mean, we brought it up. Part of me feels like there should be just some, certain things that are just without question. This person comes in with this diagnosis or these impairments. You need to assess this area. I shouldn't even say impairments, because honestly, you should find your impairments in your exam. So let's say somebody comes in with proposed diagnosis, or you develop a hypothesis of 3 diagnoses, right? You should check, without a doubt, X, Y, and Z for that person, and probably implement X, Y, and Z treatment to start with. And then you could do whatever. Part of me feels that way. The other part of me is like, no, it should be individualized. You should have autonomy. You should be able to think and reason through. But I'm gonna be real, most clinicians can't think and reason through. We teach courses. I've been to courses. Like, clinicians they're like, they want the answer. I'm like, I don't have the answer. Like, I'm not treating the patient. I come up with my rationale in the moment. I can't tell you what I'm thinking. Again, we're dry needling and we're going over the infraspinatus muscle. And same dumbass student in the class, when would you use this? Like, for 3 days straight, when would you do this? And it's like, yo, the same way when you're driving your elbow into some dude's knot, or using a lacrosse ball, or just doing soft tissue massage or cupping, whatever, instead of that, you're going to use this. Like, it's not fucking rocket science. Unbelievable how the lack of people to just want to be fucking herded through their day, or thought, like, they don't want to think.
Yeah.
I hate to say it. Obviously, we love our profession, but as a whole, it fucking sucks. I don't have the answer. I don't know. Obviously, we teach courses every month. We get a lot of different people from, like you said, student level to fellowship level, and there is just a lot of variability. And people literally just want the answer to do every time. Like, they go to a course looking for that silver bullet.
That maybe those are the ones that need to be like, here's your standardized cookbook of things. Just do this. And when if you don't get results from this, you need to find someone who can help guide you. If you don't want to do it yourself,
follow Yellow Brick Road back home.
Yeah. Like, oh my God. But yeah. Some people just don't have that drive. Hopefully the people listening in do.
Honestly, I think PT school, I know it's a cash cow for universities. Like, half the PTs that are admitted should not be PTs.
I agree.
If you don't know how to exercise, you shouldn't go to PT school, because no matter what realm you go in, acute care, neuro, peds, it all becomes dosing and progressions and regressions and knowing different exercises. Forget the manual therapy side. If you can't even do that or understand that, why the fuck are you becoming a PT?
Or talk to people too. There's some people where I'm like, maybe that gets better over time. I know I wasn't the most gifted speaker of all time, but you get some people who are just like, can't carry a conversation, or they're extraordinarily awkward, or they can't hear them, or offensive. I'm like, yeah, those people probably should be screened out. This does, again, and any field requires some grace in their talking, and we know therapeutic alliance improves outcomes. So certain people shouldn't because they have terrible bedside manner. So I don't care how smart you are, great, kudos to you. But if you're a dick, no one's going to want to work with you. They're going to give up on therapy because you offend them in some way. And then you're another person that says, oh, PT didn't work out for me. Well, PT,
unless you get them better in one session, then it doesn't matter.
I guess, yeah. It doesn't hurt to be nice, I guess. But
no, I'm just teasing there. But
Cool. All right.
Yeah, I think enough ranting today.
Yeah, that was good. But all right, so there's some closing stuff. We got a full boatload of courses for the rest of this year. Yeah, hopefully we can see you guys out there. And yeah, cheers everybody. Thanks for listening.
Uh,
Oh,
no, no,
go for it. Go for it.
just cut it.
It's live, baby.
We're live. Well, at it, and then you mentioned the courses. We're really bolstering up our I guess our offerings to the PT community. We are rolling out a cert in neuromusculoskeletal manual therapy, 2 cohorts, spring and summer. So we have an in-depth, robust curriculum for that. We have our online mentorship as well. Maybe you don't want to go the certification route, or you're just across the country. Online mentorship is an option. We have online videos as well, going over exercise and manual therapy. We're going to be releasing in another couple months certification dry needling as well. So definitely pay attention to IOSMT, as we're really going to be increasing our services and products and education material and content for everybody. So we have, our podcasts, we have our courses, we have our certs. Hopefully we can continue moving this profession forward. So we, I guess, up the standard of our profession.
Nice way to close that out. All right, awesome stuff. Thanks for tuning in, everybody. Cheers.